So managing pit and fissure caries lesions, we look at this study led by Professor Reinhard Hickel, who's the Dean in Munich Dental School. They showed that by just treating with ozone on pit and fissure caries, without any other treatment, they were able to show significant reversal of those lesions in high caries risk individuals. These are lesions which had been 26 and 28 on the diagonal dent, and it allows us with our ozone to simply use a small amount of air abrasion, ozone treat in that area, acid etchant, adhesive, and the flowable composite. So when we look at the restorations 5 years later, they are successful. This is a treatment that took me less than 4 minutes for the 2 teeth 5 years previously. I believe that all these early lesions with an early infected dentin should all be managed in this manner. No local anesthesia required. Just gain access to remove some caries to allow more ozone to enter. I've used air abrasion in this case. And then proceed to ozone treat and place a flowable composite resin. The half-life of those restorations should be at least 30 years. And I believe this to be far superior to the technique of drilling a cavity in the conventional way and placing a conventional restoration. Again, the central pit area with a diagonal reading of 35 and caries infected into dentin, air abrade, ozone treat, and seal. And once again, we're dealing with a restoration which I believe should have a very long durability and far better than the conventional technique. Many dentists in the UK and elsewhere charge the same fee for these procedures as if they were doing local anesthesia, drilling, and a posterior composite. And yet, this procedure from start to finish takes approximately 2 minutes. I also believe not alone is it financially better for the dentist, but far more importantly, this is a far better restoration for the patient long term than having the conventional restorative technique. So we can air abrade, ozone treat, and then proceed by our acid etching, adhesives, and composite resin in a very simple and very rapid technique that's far superior, I believe, to the conventional method. If we don't want to use air abrasion, there are lots of small companies that produce very small burrs. SS White are one of those companies with their fissurotomy burrs. And again, doing that technique, working on the early infected dentin in that manner and placing simple restorations, I believe, is highly successful. How do we deal with aproximal caries lesions? And again, these types of lesions in the past, we used to drill the marginal ridge away. The techniques we now use is gaining access to the caries, ozone treating the lesion, and then proceeding to a minimal invasive approach with the restorative techniques, which on 7-year recall are very durable. We will never replace those marginal ridges in the way nature produced them. And by doing minimal invasive approaches, again, in the old days we would make a DO cavity preparation in these situations. Our current teaching methods are to gain access to the caries in a simple manner, ozone treat the lesion, and then proceed with a very simple restorative technique whilst maintaining the marginal ridge. So if we are to practice minimal invasive dentistry in the 21st century, I would argue you cannot do proper minimal invasive dentistry in the 21st century without having ozone as part of your daily routine. And not just daily routine, the routine for every cavity preparation you're actually producing. This is a 16-year-old girl with bulimia. This was actually treated by one of my very junior dental students, Gemma Taylor, her name is. She's now practicing, in fact, in Scotland. And she saw the patient on my consultant clinic in the hospital, the Royal Victoria Hospital. And the patient had very severe erosion from her bulimia. And the question I would ask you is, how would you manage that patient? What would you do to manage her teeth? Have we any volunteers from the audience of what you would do to manage her problem? She's already seeing a psychiatrist. She's already under medical attention. It's actually not working. In fact, I've seen her on a 5-year recall, and she is still bulimic. But the dental student did a very simple technique. Obviously, you ozone treat the areas in order to allow better penetration of the resins. And as we know from the data, ozone does not decrease bond strength. And in most of the studies, it's actually increasing the bond strength. And then she's built simple, direct, composite resin restorations over 4 visits. And we look at the 5-year recall. Yes, of course, she could have built them better freehand by better shaping and sizes, and she's only used one colour of the restorative technique. We could criticise her for that, but at the end result, it's a highly successful result for a patient who had severe bulimia and who literally 5 years later still looks like that, and I think the dental student has done a very good job. Incidentally, I also took impressions for her, and I made trays which fit deep in her sulcus. We work with our bulimics and anorexics. We advise them to fill them full of toothpaste, and then she vomits with the trays in place, so at least it's not damaging her teeth. Again, patients like this. This is a patient I treated in 1980. You're pleased to know this was before I treated him. This was an example of good British National Health Service cosmetic dentistry in the 1970s. Some people say it hasn't changed very much since. But he has a number of early root caries lesions. And we can see this patient, he's now aged 87, and so it's 22-year recall. And we can see that he's managed these other lesions very well. He was 65 in the previous photograph. So with intensive preventive methods, patients can reverse very early lesions. What ozone does is allow a lot more predictability to the reversal of these lesions. If we look at some radiographic changes, this is from a study done by Deepak Joshi in London. And what Deepak did was only removed some caries, ozone treated the cavity, and you can actually see the remineralization present 3 months later. And this is in spite of not using a good technique. If you notice, they didn't even remove the peripheral caries. And in spite of that, ozone still had a good result. This is just for experimental reasons. What you would do clinically is you would remove all the outer caries, you would leave the caries over the pulp, you would ozone treat, and you would restore the cavity definitively at the same visit. I do not do any more stepwise excavation. I don't do any indirect pulp capping. I always leave a millimetre of caries over the pulp, ozone treat it, and do a definitive restoration. I believe that is far better for the patient. Again, another study in London, and again they didn't remove the peripheral caries, but look at the remineralization which has actually occurred. Again, just following one visit of ozone treatment. Again, from Dr. Malik in Manchester, again showing one treatment of ozone, and in recall we can see his remineralization.